time for the second session of the meeting. So this session is a panel discussion, and this will be led by Dr. Shubha Phadke. So Dr. Shubha Phadke is the head of the Department of Medical Genetics at SGPJ Lucknow, and Madam is actually the teacher of most of us medical geneticists in India, and she's been the guiding light for all of us throughout our careers. So in this panel discussion, we are also going to have two new budding geneticists from NIMS Hyderabad who will be discussing their cases, Dr. Priya Ranganath and Dr. Neelam Saini. And we also have three very senior panelists. So over to you, Madam.
I'm here to unmute yourself, ma'am.
Hello, everybody. Thanks, Dr. Shagun, Dr. Khurana. I keep on seeing those WhatsApp chats and following the SFM activities, and very impressed by the enthusiastic participants who are ready to listen even at this late hours of time. I thank everybody for giving the opportunity for this panel discussion. We'll try to limit our time so that everybody doesn't get very late. Maybe Dr. Shagun can start the case discussion. Here we have our panelist with us, Dr. Ashwin Dalal, who is the chief of the DNA Diagnostic Division at CDFD Hyderabad. Dr. Nirja, she is faculty at Genetics Unit in AIMS New Delhi. And Dr. Priya, who is working for NIPS in MedGenome. So we have very knowledgeable panelists with us, along with the two young budding students of Dr. Shagun. Maybe Dr. Shagun can start the presentation by the case by the students.
Dr. Priya, please start.
Good evening, everybody. Thank you for giving me an opportunity to present a case here. Driving straight into the case, here is a 5th-degree consanguineously married couple with a history of first child who died at 9 years of age with the diagnosis of type 1 tyrosinemia. And this diagnosis was established on the basis of clinical symptoms that the child presented with, and also the TMS GCMS reports, which were a part of the investigative studies that were done for the child. The couple are now planning for their second pregnancy, and they were anxious about the recurrence in the next offspring, and hence they were referred for genetic counseling. So this is the pedigree of the family. They were 5th-degree consanguineously married couple. There was no significant family history of similar illnesses, and there was some hypothyroidism, hypertension, and now she was planning her next pregnancy. So coming to the birth antenatal history, it was basically uneventful. At around 3 months of age, there was some acute episodes. Because of this, the child was evaluated and found to have tyrosinemia type 1. She was put on phenylalanine-free formula and also was started on protein-restricted diet, but they had some difficulty to procure this formula-based diet. So they had consulted a Swedish company, but the sponsorship was approved only after 5 years of age. And meanwhile, the child's disease progressed, and the child had liver function abnormality by the age of 4 years with some enlarged kidney and thrombocytopenia. And the child was advised liver transplantation with high risk. And by 8 years, because of the complications, the child succumbed. And but the sample of the child was stored. Now, they had done some previous investigations for this child. The tandem mass spectrometry clearly showed there was increased level of tyrosine and methionine, and GCMS showed increased levels of succinylacetone. They also had done a HPLC, which showed an elevation of tyrosine. So based on all these reports, we had a diagnosis that this was a 5th-degree consanguineously married couple with first child with clinical features and investigations, which were suggestive of tyrosinemia type 1, and the molecular testing of the first child had not been done. There were no blood or other samples of the child that were available. So clinical exome sequencing of the couple was advised at this point of age, or at this point of time. So in view of previous child with tyrosinemia, we did a pre-test counseling. So tyrosinemia, as we all know, is an autosomal recessive disorder. It has a risk of recurrence of 25%. Because we didn't have the exact disease-causing mutation known in the child, we offered the exact mutation had to be known in order to offer any kind of prenatal or pre-implantational prenatal testing or pre-implantational genetic testing. So clinical exome sequencing of the couple was discussed with, and the cost and turnaround time and implications were also discussed. So the clinical exome sequencing report presented like this. We found one likely pathogenic variant in like both parents were heterozygous for this likely pathogenic variant in the FAH gene, which is associated with tyrosinemia type 1, which was expected. But also we found that the both parents were heterozygous for another variant, which was a variant of uncertain significance in this DHX38 gene, was associated with retinitis pigmentosa 84. When we look at this kind of picture, we have to understand that there is the degree of closeness of relationship in a consanguineous marriage determines the proportions of the shared genes. Therefore, a second or a third degree consanguineously married couples can be carriers of more than one autosomal recessive disorders. In such conditions, we do a Bayesian calculation. So we give a probability calculations for them. And here we see when the probability that a child would inherit a hypothetical disease A and disease B, both these disorders would be 1 in 16. Only one of the disorder would be 3 in 16, that is A or B, 3 in 16 each. And neither of these disorders would be 9 by 16, which would roughly account up to 56%. So based on this, the prognosis of these conditions were discussed, reproductive options were discussed, including the prenatal diagnosis, the role of pre-implantational genetic testing, and IVF donor testing. IVF donor, either with a donor sperm or a donor egg. And the testing of this variant of uncertain significance in this DHX38 related phenotype would be possible, but the choice was left to the couple. And the couple decided to discuss it with their extended family. Thank you.
Thank you, Priya. Before I start sharing my screen, can you stop your
yes,
sharing your screen? Okay. So before, till I start, a question for Priya herself. Is my screen visible?
Yes, ma'am.
So the first question to Dr. Priya herself, as a clinical geneticist, what do you think that what was good about this particular case from the angle of we trying to help them? We need some information. So what were the good things about this case?
Right, ma'am. So actually the best part about this case was the first affected child was properly worked up thoroughly. So we had a clinical diagnosis which matched with the symptoms of her case, and we had even the some of the biochemical testing like TMS, GCMS, which correlated with the first child's phenotype. So we pretty much knew what were the variants we were looking for before we ordered a prenatal testing, the carrier testing.
What was the limitation, the thing which could have been avoided? As a message when so many obstetricians are listening,
right.
What was the thing which could have been done?
So the fetus sample could have been stored. I mean, DNA, as we know, stays for a very long time. So we could have at least had a cord blood sample. Sometimes even a cord tissue, for that matter, could be saved for a long time, and the DNA could be
this child survived for quite long time.
Yes.
So maybe the filter paper, you can ask the laboratory who has done this amino acid levels everywhere. Maybe we can just try to find out if we can get some sample somewhere, even a filter paper sample also. So that would have been the best thing, because here, though we are very quite sure that this was tyrosinemia. So to confirm this, the most important diagnostic level of succinyl acetone. So are there any causes of increased succinyl acetone other than tyrosinemia?
So succinylacetone is a very specific marker for tyrosinemia type 1 map. So whenever we get the tyrosine elevated tyrosine in TMS, we still we are not very sure what it could be. It could be still liver disorders, it could be transient tyrosinemia, it could be type 2 and type 3 tyrosinemias. But having a succinylacetone in the urinary GCMS gives us a more specific diagnosis kind of a thing, where we can be very sure this is a hepatorenal tyrosinemia.
So this was the point which I wanted to highlight, that diagnosis of the proband, if it is very definite, then even if you test the parents for carrier testing, as was done in this case by next generation based testing, that could be really helpful, because we know what is the disease in this particular family, and hence if we find some sequence variations in that gene, for that particular gene tyrosinemia 1, we can be very sure that this was the cause of the phenotype in that particular child. Otherwise, many times what we get an information that the baby had convulsions and died at 3 months, or baby had epidermolysis bullosa. What the picture shows as skin lesions may be epidermolysis bullosa, it may be some septic infective disorder, lot of things. So the diagnosis of proband is very important, even if we are going to do carrier testing on the parents. So now the question to Dr. Ashwin. If this child had died at 5 months of age with bleeding episode and jaundice, and the same sequence variant was identified without biochemical confirmation of tyrosinemia in that particular child, what would be your opinion using this for prenatal diagnosis?
So here we won't be really able to classify that this is a disease causing mutation in this particular child, because there could be other reasons of bleeding episodes and jaundice in the previous child. Hence, it will be difficult to directly go for a prenatal diagnosis when the variant is not like you're not able to correlate either clinical or biochemical evidence with the variant that has been identified. So this creates problems when you want to use a variant in prenatal diagnosis and you're not sure of the diagnosis in the previous child. So that can be a problem.
The message is that unless the diagnosis of the proband is confirmed by some technique, which is a gold standard for diagnosis of that technique, or if you have a sample where you can confirm the same sequence variations in that particular sample of the proband, prenatal diagnosis based on such sequence variations will have a lot of limitations. We could get a lot of such cases where the child proband is not alive, that there is very limited information, and still in about say 30% or so, I don't know what is the experience of Dr. Nirja, that we find, so we can identify mutations or disease causing variations in the parents, even if the child is not alive. But of course, when you provide prenatal diagnosis, we ourselves are really cautious and worried whether there can be some error rate or not. So in such, if this is a biochemical disorder, if the particular disorder, something like the previous child had microphthalmia, and we have identified some sequence variations which is of uncertain significance or likely pathogenic in parents. So what would be your plan or strategy to do prenatal diagnosis in such type of disorders where ultrasound can detect that particular some part of phenotype of that particular family?
So we may have such situations where some of the syndromes may have a ultrasound detectable abnormality, and many times then people will think that we can use only the ultrasound and no need of doing a molecular or invasive testing. However, we should remember that many of these syndromes or conditions show variable expressivity, and all patients of a particular syndrome may not have that severe of a phenotype every time, and still the disease may be present. So wherever possible, it is always good to do prenatal diagnosis using a molecular test rather than relying on just a ultrasound based prenatal diagnosis.
Dr. Ratna already has shown so many cases where the fetus had, say, Mickel-Gruber syndrome or some other syndrome, and the sequence variation was identified, making prenatal diagnosis easier next time. So it helps definitely for providing early and better prenatal diagnosis. But sometimes what is our experience in one such interesting case which I would like to share, that the previous child had microphthalmia, and we identified a sequence variation in a gene which was newly identified for microphthalmia, and there were only 2 patients and none of them had intellectual disability, while our patient had intellectual disability. Then we know that when we consider this variation as of uncertain significance, then I was very hesitant, and we discussed with the family and decided that we will prefer ultrasonographic diagnosis, because if you identify the same sequence variation in the fetus, and if you see ultrasound shows normal orbits and normal lengths, then probably termination would be difficult. So if variation is of uncertain significance, then sometimes you have to take help of ultrasonographic detectable abnormalities, and naturally there will be some uncertainty, and this has to be communicated to the family because the diagnosis of the proband or the sequence variation identified in the proband or carrier parents may be of uncertain significance. When a lot of patients now, everybody has seen reports of NGS-based testing, and all these words are written, like variants are classified as likely pathogenic, and then criteria ICMG guidelines has given PM1, PM2, lot of things. And most important things, clinicians try to say that the sequence variation identified in the gene matches with the clinical phenotype. So there are 2 questions to Dr. Ashwin. One is these PP3 criteria. It means softwares predicting that this particular sequence variation is likely to be pathogenic. So as a now with everybody aware of computer and software and their power of software, we feel that this is very, very important. And secondly, as a clinician, we feel that if the sequence variation matches with the phenotype of that particular gene, then we are also very sure. So how would you like to tell the fetal medicine specialist the utility and limitations of both these particular tools to classify a sequence variation?
So, because of all these confusions, we have a clear-cut guideline from ACMG to classify every variant into either a benign, likely benign, VOUS, likely pathogenic, or pathogenic. So here, the basis is that you use various evidences like frequency of that variant in the population, as well as whether that variant has been reported earlier in similar patients. And the last one is the one what Dr. Shubha told is the pathogenicity prediction software. Now, the problem with the pathogenicity prediction software is that there are more than 100 such tools available, and each of them uses different evidences like evolutionary conservation or effect of the particular variant on the protein structure, etc. However, we should always remember that these are all predictions based on certain criteria, and they may not always be the correct answers. So based on all these evidences which are given here as coded as PM1, PM2, which are related to the population frequency, as well as the PP3 related to the prediction, we may get a certain prediction like either a VOUS or a pathogenic. But the most important decision to say whether this is a disease causing variant in that particular patient always rests when it matches with the clinical phenotype. So that is the most important step to decide whether this is a disease causing variant in this patient or not. And by convention, we would like to use likely pathogenic variants or pathogenic variants for doing a prenatal diagnosis. and never a VOUS for doing a prenatal diagnosis. So to classify really a disease causing variant, we have to use both the variant classification as well as the phenotype match, which could be either in the form of a clinical phenotype or a biochemical investigation, as in this case, and then only attribute the variant as a disease causing variant.
Okay, that stresses the importance of classifying the variant. And again, Dr. Ashwin has told variations of uncertain significance. One will not use them for making prenatal diagnosis and irreversible decisions like termination of pregnancy. But even if, regarding likely pathogenic variant, what would you like to tell that what is the possibility that such a variant which is labeled as likely pathogenic is really causative or not? So is it 100% or it is less than 100%, and what is the magnitude?
So likely pathogenic we are saying because we are not yet fully sure that this is the disease causing variant, because either it is not a loss of function variant, or this variant has not been reported in multiple patients with a similar phenotype, and hence there is always a doubt. So unless this likely pathogenic variant is accompanied with a clinical phenotype match, it becomes difficult to label this variant as a disease causing in that particular patient. So we should always try to see that even though the likely pathogenic variant which has come as a prediction based on various evidences, the ultimate decision that whether this variant can be used for doing a prenatal diagnosis and termination should rely basically on whether it matches the clinical phenotype or the biochemical phenotype in the previous child or the affected child, where it gives you enough confidence to say that this is going to be disease causing.
Okay, so it means that based on a variant which is reported as likely pathogenic variant, the family can go ahead with prenatal diagnosis, and a fetal medicine specialist or geneticist can offer prenatal diagnosis based on that. But however, some of the variants which are labeled as likely pathogenic variants may be harmless, and hence the counseling should include that because this is not a definitely pathogenic variant, sometimes there may be small possibility of false positive or false negative prenatal diagnosis is there. So this usually happens when there is a novel sequence variation, and we do convey to the patient and family that because this sequence variation is not reported in many other patients, and hence the possibility that though the sequence variation is not present in prenatal sample, still the fetus may be affected, and the small possibility cannot be entirely ruled out. So I think documentation of limitations of doing prenatal diagnosis based on the likely pathogenic variants is very essential, because if the prenatal diagnosis shows that fetus is affected, they may terminate the pregnancy. But if you say that the fetus is not affected and later on after birth found to be affected, then that false negative diagnosis you have to be able to explain and need to document in advance. Coming to the other question, Dr. Nirja, I don't see that. Where is
here,
Dr. Okay, right, sir. Okay. So, do you think there are any lacunae in the evaluation of this particular case?
Okay, ma'am. If we talk about the proband, then as it has been discussed already, that because it's a long journey for the patient died at the age of 9 years. So probably we could have saved the sample earlier because of the multiple visits to the specialist. And with regard to the preconceptional counseling or periconceptional counseling, when the family is coming for the counseling and we are offering the clinical exome testing, then probably because being a consanguineous family and otherwise also, we can probably give a full information about the incidental possibility of getting some extra information apart from the mutations that we are expecting in this particular family. So that will just kind of prepare them for the another incidental finding in their when we are doing such extensive testing.
Okay, so really we can try to get some biological sample of the child. And Dr. Nirja, do you remember some interesting ways of getting a sample of a child who is not alive?
Yes, ma'am. So, ma'am, because of the Hindu culture, there is a ritual that some people preserve some cord tissue. So we have some experience of one family had congenital neutropenia, and incidentally they had preserved the cord, which was later on used for the testing. So that is one option. And nowadays, though it is not very very much acceptable and widely, but still it is being widely used. The cord blood banking, which is also being used, that blood can also be taken, explored for the testing. And thirdly, because of the newborn screening gaining is on rise in various states, we can also look into the possibility of dried blood spot in that particular state if the newborn screening program is available in that particular state.
Right, so we can try our best even in this case also, because tyrosine and all those tests were done, which were done by maybe tandem mass spectrometry. There might be filter paper sample somewhere in that lab, and one can try to get or make all efforts try to get those samples somewhere. And because we haven't done the testing in that particular child itself, so probably we will always feel there may be some small injury. In this case, the situation was much simpler because direct diagnosis of tyrosinemia was confirmed by a technique which is a gold standard. But sometimes what happens that there is general picture, epidermolysis bullosa, some acidosis, and then sick infant dying, and then we get a mutation in MSUD, maple syrup urine disease, and something like that. So in that situation, if we haven't tested the baby, then probably for the mutation, then we really feel hesitant and fear sometimes there may be some error in the prenatal diagnosis. Dr. Nirja, now this is the incidental finding about sequence variation in a gene for retinitis pigmentosa. So will you like to discuss an option of prenatal diagnosis for retinitis pigmentosa in this case?
So first of all, while we are doing the pre-test counseling, then we need to tell them that every healthy subject is a carrier of 5 to 8 recessive genetic disorder, and in this specific case there is a possibility of recessive disorder is likely because of the consanguinity. However, because this retinitis pigmentosa variant is of variant of unknown significance, and retinitis pigmentosa is a genetically heterogeneous condition, so it will not be a very straightforward option for a geneticist or a physician to offer straightforward offer prenatal diagnosis in a straightforward manner. So this needs to be discussed because there is no phenotypic expression in the fetus, which we can look into if we are trying to make a clinical correlation. So it will be a really challenging situation to offer prenatal diagnosis in this particular family. But at the same time, we need to keep in mind, because of the consanguinity, there is a possibility of getting this variant, and we may not have the clinic functional assays or clinical documentation in fetal life. So it is going to be challenging to offer prenatal diagnosis in this particular family, in my opinion.
Maybe I will also like to get Dr. Ashwin's opinion about offering prenatal diagnosis, because every time, see, lot of things, we know that the counseling has to be non-directive, and the patient's family's decision whether to terminate or to do prenatal diagnosis, lot of things. But there is a small difference between the situation for offering prenatal diagnosis in this situation, because here I think they would like to test for retinitis pigmentosa because it is a severe disease, but they are not sure, they will not understand the meaning of variation of unknown significance. It means they may be terminating any absolutely normal child also. So in that situation, about doing prenatal diagnosis based on a variation of unknown significance without any case of that particular phenotype in that family. So what Dr. Ashwin would like to say about it?
So yeah, again, I would agree with Kirja that as a general thing, we would not prefer to do a prenatal diagnosis with a variant of unknown significance in hand, especially because it entails taking a irreversible decision wherein we are not sure about the particular diagnosis. However, in this case, the issue is that ideally, according to my personal opinion, VOUS should not be reported in a carrier screening. So that is the first mistake. I think what many labs do is that once a VOUS is reported, now how can you tell the family that we will test or will not test? That makes all the counseling job much more difficult. So in an ideal situation, we would have liked that VOUS variant should not be reported in a carrier screen. However, now once it has been reported, and now it will be up to us to kind of talk to the family, because we are already going to do an invasive procedure for the tyrosinemia gene. Now, additionally, whether to look for this particular gene, keeping in mind that correctness of the prenatal diagnosis, and also many times because the VOAS has already been revealed to the family, we many times do end up doing a prenatal diagnosis based on that, but that would be only after a proper documentation and talking to the family about the risk of doing this. But that's not really ideal. But problem is, once it is revealed to the family, then they always are in a doubt of whether to do or not. So I think in such situations, then we'll have to really talk to the family and clearly document that you are doing prenatal on a VOUS because of these problems. But ideally, you would not go with it.
I think Dr. Ashwin has really clarified that for carrier screening, unless that particular variation is either matching with the phenotype or definitely very well known pathogenic variation, without that other variations, if they are reported, then I think, because for likely pathogenic variations also 10% of them may be not really disease causing. For variations of unknown significance, maybe more than 50% or even more than 90% may not be really disease causing. So family does not know all these things and cannot understand that science can be can have so many limitations and uncertainties. So it is basically as our policy as a geneticist or even fetal medicine specialist to really what to be told to the family. So here telling everything is uncertain, everything is unknown, and you take your own decision, and saying that the counseling has to be non-directive and put the ball in the family's court is not probably correct. So because now many laboratories are just offering carrier screening to all couples, and then one should be very careful about getting such type of variations of unknown significance and offering them prenatal diagnosis without their family having any such disease. Regarding tyrosinemia, this was very definite because there is a child with that disorder. But if there was no child with retinitis pigmentosa of this variety, so I think the variations of unknown significance should not be discussed in carrier screening panels, and based on that, prenatal diagnosis offering should not be correct. Though medico-legally we will keep us safe by writing and documenting everything, but one would always wonder whether the family and ourselves, whether what we have done is ethically right or not. Regarding this question, we have already discussed about prenatal diagnosis, and VOES also we really discuss all these in details. As we also said, there sometimes such type of VOEs for other common autosomal recessive disorders like epidermolysis bullosa, the similar type of lot of uncertainties do arise when we do carrier screening of the parents. I think this issue also we have really discussed, because we thought that carrier screening now panels are offered to all pregnant women. In this case, because prenatal diagnosis is one option, and there were probably two diseases may be occurring together, and that's why the geneticist offered another reproductive options like OVA donation or pre-implantation genetic diagnosis. So when will you consider offering OVA donation or doing prenatal genetic diagnosis for monogenic disorders?
So in India, PGD for monogenic disorders is not very widely available. It is so one need to have, as we have discussed, that we need to have a certain variant, pathogenic variant to offer that particular testing. However, the OVA donation, which is one has to ensure that the donation is from the established non-carrier donor. So one need to screen for that particular variant in that particular, from that particular donor also. So that becomes very important, because the donor screening, OVA donor screening may not be very widely available for the common disorders also. So like thalassemia screening donor. So if we are looking into one family, then we are sure that we have screened that particular family for common disorders also, and for the disorder in question in that particular family. But if we are using donor OVA, then we are not sure that that donor has been tested for that particular variant or for the common disorders. And there is no such, I think there is no such policy for doing the donor OVA testing for the common genetic conditions also. So that way one needs to establish. So it may be a related donor OVA where probably the testing for that particular variant in question in that particular family is done. So coming to the prenatal implantation genetic diagnosis for monogenic disorder, as I have said that it is not very widely.
Specifically when you offer these options, because even with prenatal diagnosis, possibility that the fetus is unaffected with at least one disorder is 75%. Main disorder in concern is tyrosinemia 1. So 75% chance is there that the child would be normal. So yes. In that situation, when will you offer OVA donation, or when will you use pre-implantation genetic diagnosis? What would be the success rate as compared to the 75% possibility of getting normal baby with normal conception? Because many times patients are offered, so what they feel like, if you do pre-implantation diagnosis, the normal baby is guaranteed. So yes. They feel that this is a very easiest option. So what else issues we need to consider?
So even if PGD is offered, then the person has to undergo the process of IVF. The success rate of IVF itself is 30-40%. It is not that high. Whereas prenatal diagnosis is, if it is done with the natural conception, the success rate is much more higher as compared to the PGD, which is about 75%, as you said. So I think the prenatal diagnosis of using the natural conception method should be preferred probably as compared to the PGD related, because of the unforeseen problems that a family can have, and because of the limited success rate as compared to the direct prenatal diagnosis.
So right. So basically, a pre-implantation genetic diagnosis or OVA donation, they need IVF, and hence IVF related issues, increased risk of other birth defects, IUGR, as well as low success rate has to be discussed. And naturally, there will be some situations where the family has done 2 or 3 prenatal diagnosis every time fetus was affected, or there are some translocations where there is always imbalanced gamete and something like that. or the family is very, very sure that they don't want to go ahead with MTP and so on. So under such limited situation, one may offer pre-implantation genetic diagnosis, but otherwise, even if it is offered, they should know that the success rate is less than what is there with the normal conception. And if the termination of pregnancy is acceptable, which is there in most of cases in India, probably this option will be needed only for a limited number of families. So coming to the last batch of questions to Dr. Nirja, what is your experience about diagnostic yield of parents' NGS if the child is not alive? Now we are doing this commonly, and in fact, it's really when you identify the variation and in that particular family for the causative disorder, not only parents, we are also very, very excited. So, but what is the diagnostic yield as per your experience?
So, ma'am, we have not formally calculated the yield, but the experience says that if we have a homogeneous kind of phenotype, a specific phenotype, then the yield is better as compared to the non-specific phenotype. Like early neonatal death, the yield may not be that much good, recurrent early neonatal death, but maybe with recurrent high drops, you may get some answer. For Meckel-Gruber syndrome-like fetuses in the previous pregnancy, you may get some answers. But for the non-specific phenotype, early deaths, stillbirths, you will not have answers. So even if the carrier exome is done, then you may not get answer in those conditions where the phenotype is non-specific. But for the specific phenotype, most of the time, the phenotype, the exome sequencing gives us the result, if it is done simultaneously. So coupled duo analysis should be done simultaneously, not one by one, so that the interpretation becomes easier. Yeah.
Right. This is very important. And by chance, if something is missed in one person, one of the spouses, and then probably you can relook at that particular gene in the other spouse. The other thing is what to offer: whole exome sequencing, clinical exome, or now there are many labs have some panel for carrier screening, which includes some autosomal recessive disorders. It may not have all autosomal recessive disorders. So what do you prefer usually to get it as a test?
Yes, ma'am. So, ma'am, here there is a concept of expanded carrier screening, though there is no formal this thing which is being followed in India, but so there can be 2-3 situations. So one situation is that the family has a high risk. Family is high risk in the sense that there was a previous affected child for some particular problem.
So I think we are talking about that at present only. So if there is some family with some child with abnormality, would you prefer carrier panel for carrier screening or clinical exome?
I think testing for using clinical whole exome and clinical exome needs to be discussed with the family, and I would prefer to do whole exome as compared to clinical exome because of its ability to detect more disorders for that particular family, provided the lab is reporting the pathogenic and likely pathogenic variants in the couple as compared to the...
Yeah, so the panels for carrier screening, there are no specific guidelines which genes they are including. So if I think that the patient had some inborn error of metabolism in the group of maple syrup urine disease or something, I will have to go and look whether all those genes are included in that panel or not. So sometimes it may happen that that epidermolysis bullosa new gene has identified in last year, and the panel for carrier screening does not have it. So basically, I think when there was a child with some disorder and not alive, and we are testing the parents, clinical exome or whole exome testing also always should be done, because in spite of because panels for carrier screening, they are giving at some low cost as a package of both of them. but probably we do not know, and in fact there is no point in looking at all those genes in them and trying to see if whether there are those genes which we want or not. So I think one should not refrain from doing such type of panels for carrier screening because they are relatively less costly. Would you do testing on amniotic fluid simultaneously? Because I get see some papers or sometimes obstetricians doing everything together.
No, if I do not have the results of exome sequencing in front of me, then I will not be doing the amniotic fluid in any case. So invasive testing has to wait for some time because it is going to be irreversible. If abortion happens, then though the rate is low and we don't know what will be the exome's results. So we cannot offer.
So very high possibility that in spite of taking amniotic fluid, we are not able to provide any result to the family. So I think such type of, if the fetus has some abnormality, ultrasonographic malformation, then it's justified that you do together. But otherwise, I think unless parents testing is done or some way or the other, you have identified the causative sequence variations in that particular family. So I think that we have taken care of. Maybe Priya will tell if we have missed something and she wants to highlight from her experience of dealing that particular case, what were the issues. So that brings end this particular case scenario. Everybody has to know that when we identify thousands and thousands of sequence variations in the whole exome or clinical exome, then lot of them are benign, and when there may be some pathogenic, but most of them are really yellow in color, variations of uncertain significance. So though on one way whole exome sequencing is very, very beneficial and NGS-based testing gives us diagnosis when nothing was possible. But once you identify variations of unknown significance, I sometimes feel it's like a Brahma Rakshas standing in front of you and you don't know what to do with that. So one has to be very, try to become more and more comfortable. I don't think we have solved the problem, but over years, I think gradually as more and more NGS is being done, we have become comfortable in counseling regarding variations of unknown significance. And as there will be more and more functional studies easily available, the labs may do functional studies immediately and may provide you that probably this is less likely to be a pathogenic, more benign. So classification of VOAs again into pathogenic and benign will be possible when the functional studies are useful. And this slide I mainly prepared because during COVID times, we were doing counseling on telephone, and really to talk of all these complicated things on phone and telephonic counseling was really, really a great challenge. So thank you very much. Maybe I will stop sharing so that the second case can be taken if the time permits. I don't know how long the participants are interested. Okay, Dr. Neelam, please start.
Dr. Neelam, go to full screen.
Is there some audio problem from Neelam's side?
Dr. Neelam, unmute yourself.
Yes, sir. Yes, ma'am. Good evening, ma'am. I hope my screen is visible, ma'am, and my
Yeah.
voice is also.
Your
Just
screen is
full
visible,
screen.
but you have to go full screen.
Yes, ma'am. 1 second. Good evening, all, and thank you, Shubha ma'am, Shagun ma'am, and SFM for giving me this opportunity. So now we will directly go through the case. And this is 33-year-old lady, Gravida 2, Paravan Live 1. She has come, referred to us at 17 weeks of gestation. And with the history of non-invasive prenatal screening suggested increased risk for sex chromosomal aneuploidies. This was non-consanguineously married couple, and the pregnancy was IVF conception in view of secondary infertility, and they were referred for genetic counseling. So this is the pedigree, the non-consanguineous couple, and the age of the mother was 33 years, and she had one live 7-year-old female girl child, healthy, and now 17 weeks pregnancy, no other obvious family history significant. And then in her obstetric history, first pregnancy was conceived spontaneously, and then LSCS was done in view of meconium strain liker, and that was girl baby, 2.8 kg. And now the child is 7-year-old, and she's healthy and normal, having age appropriate developmental milestone. And coming to present pregnancy, this was the IVF conception in view of secondary infertility. Day 5 embryo transfer was done, and the period of gestation according to first trimester scan and from the embryo transfer date also corresponding at around 17. So it was 17 weeks of gestation when she was referred to us with the NIPS report. In first trimester screening, there was no history of any medical illness, no history of any spotting or bleeding vaginum. There was, she was taking folic acid regularly, and there was early pregnancy viability scan was normal. And nuchal translucency in present pregnancy, nuchal translucency scan was normal. First trimester combined screening, she opted for combined aneuploidy screening, and that suggested high risk for trisomy 21, that is more than 1 in 50, and then low risk for trisomy 13 and 18. In second trimester, early TIFA scan was done at 16 weeks of gestation, and fetal growth and LICA was adequate, and there was no obvious fetal structural anomalies detected. No soft markers were for aneuploidies were detected on early TIFA scan. And then because there was high risk for trisomy 21, options of non-invasive prenatal sampling and amniocentesis was discussed with the couple, and the couple opted for the non-invasive prenatal screening. And then non-invasive prenatal screening suggested in that fetal fraction was good, that was 28%. There was no aneuploidy detected for chromosome 21, 18 and 13. But sex chromosomal abnormalities reported by lab was borderline risk, and specific sex chromosomal aneuploidy was not mentioned in the report. So now few points regarding sex chromosomal aneuploidies. These are the most frequently occurring group of chromosomal disorders characterized by loss or gain of one or more sex chromosomes. The most common are Turner syndrome and Klinefelter syndromes, and also we have trisomy X and 47XYY and others. So here the many important issues in the counseling are variability of phenotype and unpredictable phenotype, because they have variable spectrum from completely normal phenotype. Some may have some phenotypical abnormalities. And then positive predictive value for NIPT for sex chromosomal aneuploidies is also very less, not like trisomy 21 and 13, 18. And then now the option, because it came risk for sex chromosomal aneuploidies, options of invasive testing was also discussed with the couple. And then rare possibility of some maternal mosaic Turner syndrome or sometime trisomy X was also thought about. Then we know in the sex chromosomal aneuploidies, the prevalence is much more higher than other trisomies. Like Klinefelter, they can have prevalence from 1 to 500, 1 in 500 to 1 in 1000 live male births. And then usually they have they are usually having normal, and they won't be as much, they won't have significant intellectual disability like Down syndrome. The most common issues here will be in hypogonadism and infertility. So that because now we have options of hormonal replacement therapy and assistive reproductive techniques are available. So that can also be treatable conditions, and they can have some mild learning disabilities and mild developmental delay, but most of them will be phenotypically normal. And many studies are also proved that prenatally detected sex chromosomal aneuploidies have much more better prognosis. So these were about positive predictive value of sex chromosomal aneuploidies, that is very variable. Like for Turner syndrome, it will be somewhere variable between 26 to 97%, and like for other chromosomal aneuploidies also. So to conclude, this is second pregnancy of non-consanguineous couple, and this was IVF conception, so it was a previous pregnancy. First trimester combined aneuploidy screening suggested high risk for trisomy 21. Then NIPS was opted by the couple, and the borderline risk for sex chromosomal abnormalities was detected in non-invasive prenatal sampling, and they did not opt for invasive prenatal testing. And then maternal karyotype was done simultaneously for as a routine recommendation in our institute. So that was normal 46XX, and now this pregnancy is ongoing, and they are planning to continue the pregnancy. Thank you.
Okay, thank you, Neelam. Can you stop sharing your screen?
Yes, ma'am.
Okay, so this is a representative case, the real case, and the issues for discussion are mainly highlighting issues in prenatal screening, unexpected findings, especially unexpected findings of sex chromosomal abnormalities, which have there is no intellectual disability, and outcome is a lot of uncertainties there. Then many times when NIPS is done, there is a infertility as an indication for IVF in that family. That leads to baby being very precious. There may be previous history of bad obstetric history, previous normal children, or previous child with intellectual disability, failure IVF. So all these issues can complicate the counseling and screening for aneuploidies. So we should take these questions first to Dr. Neelam. Did you find out what was told to the patient while offering first trimester screening? And then what was she was told about when she was offered NIPS? Because she came to you after that NIPS report. So do you know what was the situation?
Yes, ma'am, that counseling before first trimester aneuploidy screening was not offered at our institute, but if we would have offered that counseling, then we would have informed her that like before aneuploidy screening, that all pregnant women are at risk of having fetal chromosomal abnormalities because of that
but basically, okay. Was she offered this biochemical screening first, or she was offered both NIPS and biochemical screening?
Both options were discussed, ma'am, with her, biochemical screening and NIPS, but because of the cost and
what I mean is, you have to find out when she came to you, what was her referring obstetrician has done already. This is just a point to stress, because most of the times when the patients come to us, they are already with some prepared mindset, because whatever the obstetrician has told them. And hence we need to first find out what is their frame of mind, because they have made some decision and then they come to you. The second thing is whose ova was that? Was her self ova?
Yes, ma'am. This was a self cycle. Yes, ma'am. This was self cycle
when the
IVF.
family came to you with the result, did they talk about mental retardation? Because whenever any NIPS or any screening test is positive, the family has been usually told that the child will be mentally retarded. So do you remember that what was the family's main concern before you started giving counseling?
Yes,
if you don't
no,
remember, it's okay. Okay.
No,
because
mental
most of the
retardation was not told to them. That they were very sure. Only thing that they were told that this report is abnormal. We have to discuss with further. We need some discussion.
That is very important, because many times they have been told that about mental retardation, because mainly all testing is done for Down syndrome and mental retardation. So now coming to these questions, Dr. Mirza, would you have offered NIPS if she had come to you in first trimester before doing biochemical screening?
Okay. So, ma'am, she is a 33-year-old, one normal issue, normal karyotype, secondary infertility, and IVF conception. So, I will discuss both the options with the lady. And because it's a precious pregnancy, I think because NIPT has more predictive value and she is at borderline age. So I will give both the options, but preferably probably NIPT in this particular case.
Yes, in fact, it has a very high diagnostic yield. 99% of Down syndrome babies will be picked up because that's what we are doing NIPS main screening mainly for trisomy 21. And secondly, it decreases the need for invasive testing. So anybody who is such a high risk pregnancy, precious pregnancy, will not like to go for invasive testing. So here in India, we do not have any strategy for the population to find out cost effectiveness. Everybody is going to pay for the test. So I think somebody who wants screening but wants to avoid invasive testing, then I think NIPS should be offered rather than keeping it as a second level of test. On the contrary, if you identify some high risk on biochemical screening or ultrasound with high NT, then probably it's very important that you do invasive testing and look for all chromosomes. But NIPS, probably I myself feel that should be kept an first screening test for particular select situations where the risk is high and the family wants to avoid invasive test as much as possible. So secondly, how early would you offer NIPS?
Ma'am, as maternal plasma must contain adequate amount of fetal cell-free DNA to obtain a reliable test result. So 10 weeks seems to be the lowest gestation, which is most appropriate.
But technically, it's okay. Technically, possibility is one thing. And second thing is really the usefulness and the clinical situation. So what would be the right time to?
So I think, ma'am, in this scenario, maybe 11 to 13 weeks is a better time because it provides you an early opportunity to do the invasive testing if it comes out to be positive. But however, because fetal DNA as well as placenta both are from the CVS, both are from the placental tissue, amniocentesis is better, more preferred as compared to the CVS testing in such scenario. So
I myself feel that when the risk is not very, very high, and because 50% of aneuploidies like trisomy 21 get spontaneously aborted by 14 weeks. So doing early, you may detect more, but some of them may be spontaneously getting terminated. So probably better to do it at 13, 14 weeks when the ultrasound is already done, and then probably if needed, invasive testing is needed. NIPS, the positive predictive value for Down syndrome is so high that if it is really positive, you can do immediately CVS, and if it is negative, then probably. So if NIPS can be delayed and though technically possible at 10 weeks, I don't think it is so necessary to rush NIPS to that early stage. Probably doing 14 weeks, and then if it is positive, accordingly action further can be taken. Dr. Ashwin, what information need to be told in pre-test counseling for NIPS?
The pre-test counseling would be same like any other test that you would tell a pre-test counseling. It should basically mainly involve why you are advising this test. So what information we are going to get out of this test. The second thing most important to be told is that what this test is going to rule out or what this test is not going to rule out. So many times people are mainly bothered about the mental retardation or any abnormality in the baby. So we have to clearly tell them that the NIPS test is going to look for only abnormality of a few chromosomes and not really going to guarantee a normal baby. And at the same time, like any other test, it is also going to have a failure rate wherein the NIPS may come out to be normal and still baby may be affected. So the pretest counseling is basically going to remain same as for any other testing that we offer in pregnancy.
Okay, and because this test is very costly, families usually feel that it will take care of all genetic disorders or at least all causes of mental retardation. And secondly, they also feel that they have to know that this is still a screening test and further invasive testing may be needed. So this all has to be stressed. But other than that, do anyone tell about sex chromosomal abnormalities that those may be detected in pre-test counseling? So usually
that will form part of the if you are counseling in detail about the incidental findings. So we are not really looking for sex chromosomal abnormalities when you are doing NIPS, but since they are being reported, they will form part of the incidental findings.
So basically, I don't think most of us highlight about this possibility of detection of sex chromosomal abnormalities, and probably it may be necessary if you are including it in the test. Whether it should be really included in the screening test or not, probably we need to discuss some some later slides. But because they are reporting, I think we should make a mention of it, because rarely you can identify such case, and that will be again problem with the counseling. Dr. Priya, who is from the laboratory. So Dr. Priya, has she joined?
Yeah, I'm here.
Okay. Hello, Dr. Priya.
Hello.
What is your experience? Do you think clinicians provide adequate information about when you get the sample for NIPS and then you provide the result? What is your experience? Do you think the families are aware about all issues?
No, actually, we don't think so. I think the basic things are provided, but from the lab perspective, what we see is that the possibility of a no call or a possibility of a redraw. These are the things that they may not be so aware of, and therefore the compliance may not be so great for that. The other thing is that what we see very commonly, and which is a little more bothersome, is when we do the follow-up, we find that they terminate pregnancies without confirmatory testing. So in our follow-up data, we have seen about 6 to 11%. There may be other causes. They might have seen other abnormalities for which they might have terminated. But in the report, and every time when we speak to the clinicians also, we do recommend that invasive testing has to be done. So I think the gap is in that part when the patients are not counseled about the types of reports that they may get. If it is low risk, it is fine. If it is high risk, they have to go for invasive testing, and there is a possibility of a redraw because of low fetal fraction or a QC failure. And sometimes there may be a failure for which NIPT may not be recommended. You know, sometimes when we do see suspicions of maternal malignancy and such things, where a repeat sample is not going to help. So at such times, if that counseling is provided upfront, we see that the compliance of the patient is much better.
Okay. So basically, I think we need to have more awareness amongst clinicians that proper adequate pre-test counseling information should be provided, especially failure rate, because people are very disturbed by if you tell that the test has failed and repeat sample is needed. Yeah, that only delays a thing. And secondly, they feel probably if the test has failed or repeat sample is needed means something abnormal is there.
Yes, that's very true.
Appropriate counseling should be told. And they also sometimes get angry that itne sare paise liye aur upar se fir se test bhi nahi ho pa raha hai. So that is a part of inherent technology. Do you think how much you should you feel that we should tell about possibility of sex chromosomal anomalies?
I think it has to be mentioned, because the reason is that we see that 20% of our abnormalities are actually sex chromosome abnormalities, and obviously most common is monosomy X. And like we have known, the incidence is 1 in 300 at 20 years maternal age, and by 40 years it becomes 1 in 200. So it is quite common. It will be commonly picked up. But
so what is the gestation age of most of these samples of NIPS?
Yeah, like you mentioned, actually, just a few minutes before, it is about 14 weeks. Our average gestation is 14 weeks. People prefer to do the first.
Out of them, about 10 to 20% maybe sex chromosomal. Out of your positive cases, 10 to 20% maybe
about 20%. Yes, 20% are sex chromosome abnormalities as a whole. Most, about 13% may be monosomy X.
So have you follow up of those cases?
Yes.
Because
Yes.
About what those
we do follow up, actually, because usually the genetic counselors call up to find out the follow-up.
Not only positive predictive rate, but I just wanted to find out how many of them have cystic hygroma and hydrospitalis.
Usually for monosomy X, we find a good correlation, because if they have sent the ultrasound report or they have mentioned on the TRF, there will be a cystic hygroma. It is pretty common. And of course, for when we see trisomy X or XXY, we don't see any abnormality on the ultrasound. But what I wanted to make one point is that the genetic counseling is so important that we have some examples in which the patients have continued the pregnancy when they have had a diagnosis of XXX. So there is, I mean, the counseling is very, very critical, as everybody has been mentioning, because all the outcomes of all these conditions are variable, and in some cases,
okay, we'll come to that outcome in just a minute. Yeah. So as I said, that you also said that many of those who were detected 45X, some of them already had cystic hygroma or developed by the time the report was there, or so on. So I would like to tell all the audience that out of conceptions with 100 conceptions with 45X karyotype, 98% get spontaneously aborted and only 2% would continue. So basically that brings us to point that those who will be spontaneously aborted or detected as cystic hygroma, do you think, and then the 47XXX are phenotypically absolutely normal, same with 47XYY. So that brings me to the question, do you think screening for sex chromosomal anomalies is really justified? If you take amniotic fluid, you will get the report automatically. But in screening panel, if you don't include it, you will not get it. So if is it really justified, or it is just as a technically you are doing it, so it appears as a byproduct, so you also give that result to the families?
I mean, this is open to discussion. I mean, is it directed to me? This question.
Yes. So, because do you think like whatever your follow-up is there, because none of us would have that large the number of prenatally detected sex chromosomal anomalies follow. So, what do you think that if so many are getting otherwise spontaneously aborted? Personal opinion as such, is it necessary?
I think it is justified, actually, because like it has been mentioned in the presentation also, there may be other infertility and these kind of issues which may come up later. So if there is something which can be found out prenatally, it can be discussed or explain to the patients. That is what I feel. And the other thing
so
is,
maybe Dr. Nirja, sorry, please continue.
Yeah, and the other thing is technically, if we are saying it works as well as let's say other chromosomal abnormalities as well. So in general, though we will come to the positive predictive value, but in general it is about 50%, 50 to 70%. So as such, technically it is it performs very well, even for sex chromosome abnormalities.
Yeah. Oh, okay, so technically it's feasible, but that doesn't mean that everything what is technically is feasible, because technically whole genome sequencing from fetal plasma, pre-fetal DNA is possible. But at this time, what is your personal opinion, Dr. Nirja, about offering screening for sex chromosomal anomalies by NIPS?
Yes. So in our experience, we had about 1,050 ladies on which NIPS was done. And out of those, 4 had sex chromosome abnormality. And these were 2 XXX and 2 XXY. There was no monosomy. Maybe because by the time they get the NIPT, it is already 15, 16 weeks. So we do not have any 45X as in our cohort. And interestingly, both triple X were amniocentesis showed that the karyotype to be normal, and the babies were born as normal. And so there was for XXY, it was one of them was doctor couple, so they opted for termination of pregnancy, and one did not do any amnio, just terminated. So while dealing with all these cases, we found that counseling is very, very, I mean, it's not an easy job to do the counseling for such abnormalities, because the parents' perspective may be different. Whatever we tell them, they will take it with a pinch of salt, and they may not agree that it is a milder condition. So they will continue with the pregnancy, as happened with all these XXY cases in where the doctor couple terminated and other did not opt for the test and just terminated. They did not agree to our request. So I feel that it probably kind of a VUS thing, which we look into the exome, and it really complicates the counseling. And when we are doing the prenatal testing, when we are offering the prenatal diagnosis also, then also we are not telling that you will, we should be telling that the unexpected findings or incidental finding of sex chromosomal abnormality, but there also we are not telling it all the time that for prenatal diagnosis that you may get this incidental finding. That's another issue. So I think just be a little more simple, and because our population needs to understand all these things in a very simplified manner. So for me, autosomal aneuploidies looks simpler to me to explain, and probably I don't think that SCA and microdeletion, microduplications should be taken into account. And monosomy X, madam has already told that majority of them will terminate, and they will have, if they will spontaneously terminate spontaneously, and they will most of the time have hydrops and cystic hygroma. So that
which
is
are ultrasonographically detectable.
That is detectable. So 13, 14.
What about the XX, triple X case? Was the karyotype of mother done?
Ma'am, I just collected this
data. But many times the mother herself may be triple X, and
yes,
that is why the
yes.
NIPS detects it.
Especially
fetus is normal. So that indicates that triple X is absolutely harmless thing, and many normal individuals may have, and they will pass through the whole life without even getting it known. So what I want to think, we need to introspect ourselves that prenatal chromosomal analysis, sex chromosomes will be seen and you cannot avoid seeing them. But in case of screening for by NIPS, it's really one need to wonder and put our minds together for the disorders which either are getting spontaneously terminated or have absolutely normal outcome. And sometimes like even XYY. So naturally, we really wonder whether termination is justified or not, or putting the family into dilemma is justified or not. Not only that they will terminate, but making them face dilemma of something which they had not asked for is a really issue. Now, Dr. Priya, we have already probably discussed what should be told about NIPS, what to expect, but what are the issues with assisted reproductive technique? Because as in this case, and I said, there probably NIPS has much important role because it has good diagnostic and the need for invasive testing is decreased.
That's right. So with assisted reproductive technique, I would like to say a few things. The first thing is usually we have to, first thing for NIPT, we have to check whether there has been a vanishing twin. because usually in such cases we do find vanishing twin. If it comes to vanishing twin, the information on when the fetal demise happened is very important, because NIPT as such is not recommended when there is vanishing twin, because we don't know how long the cell-free DNA from the vanished twin is still there. So that's why there may be false positives. So that's one thing. And second thing, in assisted reproduction techniques, we also find that there may be twins. And with twins, of course, like even the first lecture we heard, the sensitivity and specificity is as good as singleton pregnancy. Only thing, the fetal fraction that we need to make a call is higher. So sometimes there may be a failure rate. So failure rate is about slightly higher than that of singleton pregnancies. And the other possibility, there have been some reports that in assisted reproductive techniques, when you do NIPT, the fetal fraction may be slightly lower. So the reason for this is not exactly known, but one of the possibilities is that there may be, since it comes from the maternal, from the placenta, and if there may be some inflammation during the IVF techniques, there may be increased maternal DNA. So that is just one, that is just a theory, it is not confirmed. Okay, so that may be the reason why there is dilution of the fetal fraction. And the other thing with this is, again, coming back to twins, is that there may be, if you get a high risk on twin pregnancy, you don't know which fetus is affected. So usually these are the complications that we face with assisted reproductive techniques, and about 2/3 of our twin pregnancies are by assisted reproductive techniques.
Okay, so that is another different issue for discussion. We will not go into details, because for assisted reproductive techniques, they are mostly dizygotic pregnancies, and naturally we do the possibility that both fetuses will have Down syndrome is so remote, and then having one, and then IVF से इतना successful होने के बाद में selective reduction and causing risk to the other fetus is very, very high. So really, I wonder whether screening for twins is by IVF pregnancies is really justified or not, without other than by doing ultrasonography, because what we are going to achieve by doing whether we'll identify high risk, then test both of them. If one of them is positive for Down syndrome, will you reduce that and give risk to the other fetus? All these things are really major questions for discussion for the family as well as the clinicians. We will not go into.
But just one point, actually, most of them, 98% will be low risk only.
So the purpose, I would like to highlight the audience, that purpose of these all screening tests in low risk population is not to tell you that you are at risk and then give get the test done and find out they are low risk, so they are relieved. The purpose is not that. Purpose is that to identify those 1 in 1,000 individuals who are really at high risk, and then you diagnose them in time and treated or did help the family in some way. So जो population based screening का जो purpose है, so what happens that if you just create the risk and then the family is tense and the report normal comes and they are happy. So in case of twins, you have given them that you may be at risk, but really उसकी efficacy in really helping the family कुछ नहीं हो रही हो, तो फिर twins के लिए screening test by any other method other than ultrasonography, the utility would be limited. So now coming to just a word about, you told about the reaction of patients after being told about failure of NIPS. I think we just discussed that, but how many percent of people do give a repeat sample?
We get about, I think about 60-70%. We get a repeat sample, because also depends on gestation. Sometimes when it's too close to the legal age and all that, then they may go for invasive straight away. Yeah.
Okay. Good. So, Dr. Ashwin, does NIPS tell about specific sex chromosomal anomaly? Like in this case, the lab particularly had not told what is the specific sex chromosomal abnormality. Will the NIPS find?
So NIPS could detect, like as was discussed in the earlier lecture also, like if there is a Y chromosome, then probably it will tell the presence of Y chromosome. Based on that, you may have some idea, but otherwise it will give a probability of a sex chromosomal abnormality.
And what are the causes of false positive, like 47XXX, the case Nirja told?
So NIPT false positive, there are various reasons. First of all, NIPT is almost something like a chorionic villus sampling. So it confined placental mosaicism is one of the causes where false positivity comes. Sometimes as the age increases, the mother has some of her cells having aneuploidies. So maternal mosaicism for aneuploidies is another cause. Or the vanishing queen is another cause for a false positive. So or maternal transfusion. So various
mother herself may be 47XXX, triple X.
Yeah, and many of them being normal, they may not even be detected.
Right. Dr. Priya, what is your lab data about positive predictive values?
Yeah, for each condition it is different. If we are speaking specifically about sex chromosome abnormalities, I think average ballpark to remember maybe about 50%. 50%. So like 50% it may be abnormal, 50% may be normal. But we have seen ranges from 38% to nearly 90-95% positive predictive value, especially for actually X, YY, and all those conditions can be detected quite easily. So I think for the case which was presented, when they said it was borderline, one possibility would have been just to repeat the sample a few 2 weeks later or so. They might have had a clearer picture. And as such, the type of abnormality can be detected, but sometimes it can be difficult. So, so the pattern in which it is seen is pretty clear. So the type of abnormality actually can be identified. So positive predictive value, we can think of it as about 50%.
Okay, so for the audience, like if you get a NIPS positive for sex chromosomal aneuploidy, then without doing invasive testing, one should not make any final conclusion. And invasive testing will even 50% may be normal. Yes. And do you want to add anything about causes of false positive results?
Yes, I mean, like Dr. Dalal said, it is exactly that. In about 8% of sex chromosomal abnormalities previously on NIPT were false positives. That is because as women age, we know that one of the X chromosome is lost, and therefore it mimics the pattern of monosomy X. So that is maternal conditions, which can be this monosomy X on aging. Other thing can be triple X. If the mother herself is triple X, the mother may be a mosaic for certain conditions. And other than that, we have actually observed a very strange patterns which can highlight a maternal malignancy. One is almost confirmed. And so these are the maternal factors. The others, of course, will be confined placental mosaicism. And of course, history sometimes is very important because we have had renal transplant patients. We have had some other transplant patients, in which case, if the gender is different, then there could be a possibility of cell-free DNA coming from there.
Okay. Yeah, right. So basically maternal cancer sometimes getting identified because of
yes.
NIPS is a possibility. Of course, I don't think one should tell about this possibility beforehand. What about the positive predictive values for trisomy 18 and 13?
Those are pretty high actually. So for 1 second, let me just see the data. Yeah, for
microdeletion syndrome like Prader-Willi syndrome.
For microdeletions, also again, if not only our data, in general, again, it will be about somewhere 40 to 50% for microdeletions. And I think in the first talk also, he mentioned about, I think 44% for microdeletion syndromes. So for trisomy 13 and 18, it can be about 77 to 80%.
Okay, so the point to stress is that if the disorders are very rare, then the positive predictive value decreases. And so that is why when we are possible, that aneuploidy of any chromosome can be detected. But if they are very, very rare, and then sometimes if they are detected, you need more invasive testing, because the whole purpose started by that NIPS decreases the need for invasive testing. But if you add more rare syndromes, then the possibility of need for invasive testing also increasing. So naturally, one has to keep this in mind when we are trying to look for very, very rare disorders, for which otherwise even population-based screening would not have been justified. But now they are possible and they are in our clinics. So one gets tempted that all these also can be done. Can you differentiate between 47 XXY versus 48 XXY and 49 4XY?
This is difficult.
Because, right, because 47 XXY, their cognitive function is absolutely normal. There is no mental retardation. But if it is 48 XXY and 49, there really mental retardation can be there. So just wanted to find out, because when we are screening, then the whole purpose is mainly whether you can identify and prevent mental retardation. So Dr. Nirja, what is about outcome of prenatally detected monosomy X?
Ma'am, we have discussed that majority of them will abort, spontaneously abort.
Yeah, and then
Can I just
cardiac anomalies can be looked for.
Yes.
Can I just bring up one point here, because some of the cases which we have detected, they are mosaics actually. They are mosaics. So maybe mosaics have a chance of actually surviving much beyond. So, but they would probably postnatally, they will have abnormalities. But monosomy X cases that we see, which then go on for chromosomal microarray, we see that they may be about 30% or 40%, 50% mosaics. So maybe these are the ones that survive, yeah.
Even otherwise also 45X without non-mosaics also will survive. And then the most important outcome regarding them is short stature and infertility. So these are the important problems which now probably we don't have time to discuss in detail so much. But even mosaics fertility is also seen, even non-mosaics also. So there is a series out of fertility of 150 cases of Turner syndrome. 16% had one normal conception, and out of them 50% were mosaics and others were non-mosaics. So we have to tell this all to the family, that when they feel infertility means what are the issue, treatment is how much is possible. And the most important thing is they are not mentally retarded. Though there may be some learning disabilities or some spatial temporal planning, all those things maybe, but we have to very clear they are not mentally retarded. Fertility issues we discussed. Then Nirja, what are the main issues with males with Klinefelter syndrome? Because
mostly they are normal, but they may have some learning disabilities, but it is not true for all. In some minute percentage only this can happen. Otherwise they are perfectly normal, except for the tall stature and the hypergonadotrophic hypogonadism, which leads to poor secondary sexual characters. But for this, if they are they should be given testosterone if they are identified prenatally and the pregnancy is continued, so that these abnormalities can be taken care of in a timely manner. So,
okay, so fertility, how can there be fertility also? They have fertility?
They're mostly infertile, but they can have fertility because of
like ICSI taking their biopsy, collecting sperms and
using,
so on. So altogether,
like for Turner syndrome also, oocyte cryopreservation is done for them also. ICSI can be used to take out the sperm, and then it can be taken further.
Okay, and they are not mentally retarded. IQ of all Klinefelter is absolutely is normal. It may be 10 points less than the siblings, but I don't think that makes any sense if it is in the normal.
Yes.
So these are the informations which one has to provide when the prenatally sex chromosomal abnormality is identified. So these two were another group. At least they can have some issues related to infertility, some of them or many of them. But regarding 47XXX and 47XYY, what is the outcome, Dr. Ashwin?
So as we have seen earlier in the case also, so mostly the outcome is normal, especially for 47XXX. But still there are reports of behavioral abnormalities or ADHD, and hence it becomes very difficult in counseling to tell the family that the baby is going to be absolutely normal. And problem is that whenever you speak little chance of some abnormality, immediately the parents think of termination. So it really becomes tricky, and this is not only in NIPT. We even get these incidental findings when we do a prenatal testing for some high risk for Down syndrome or something. We do get these abnormalities, and then it's the same issue to do the counseling. So
that's the point I wanted to stress, that there are so many individuals with some learning disabilities. Now the schools do their evaluation, and 16% children may have ADHD or some learning disabilities. But if they are present in 26% of XYY, then the family would decide to terminate. So I think we need to really consider ethically whether we need to do screening for them. Diagnosis, I think if you take amniotic fluid and do karyotyping, you cannot avoid getting their diagnosis. But screening for those disorders which they practically do not have any poor outcome and do not justify any criteria of for including those disorders in screening is really debatable. And I think we need to really wonder whether we should do it because it's technically possible and it's included in the package and we get it for the same cost for which you are doing trisomy 21. So it's really because it becomes sort of unethical also, no? Like we are offering the test and then because the family feels why to take risk and then they will terminate. So this is something I'm very much concerned about it. Do you see such type of karyotypic abnormalities in children evaluated for autism or intellectual disability? Like those who are really abnormal and they come to you for them. So
no, not really. So
so basically the point to stress is that by doing autism scale and some of them may be having some on the autism spectrum disorders, but really they are not that type of those who could be labeled as with developmental disability due to autism. So I think they would fall within the spectrum of normal people, and hence just because there are a lot of studies and showing scores here and increase and so on, and that too 75% children will not have even that abnormal autism spectrum score, but some of them may have slightly on the autism spectrum disorder score. So just to terminate all cases of 47XYY because the family becomes anxious. And I think here probably we are also contributing to that unnecessary terminations. So there are a lot of papers regarding this. This is one of them. People can take snapshot or look for it. And they have given detailed point-wise counseling, what information should be provided for outcome regarding prenatally detected sex chromosomal abnormalities. These are other references. All these should be read in details because when you are talking to the family, just you have seen one child with Turner syndrome with infertility, but that is not the case in all cases with 45X. So basically, unless you read all those papers and understand them and not make your opinion based on the one case of Turner syndrome, which has become sort of biased thing. The patients who are diagnosed Turner syndrome, their outcome is very different than from those who are prenatally detected and then followed up. So there are a lot of data and probably everybody who wants to counsel about prenatally detected sex chromosomal anomalies should read all those papers in details. So lastly, probably infertility is an important thing. So for IVF patients, Dr. Nirja, do you get a reference for genetic evaluation, and which test do you offer?
So if it is they're coming for infertility, then the standard evaluation for male infertility factors and the female infertility factors evaluation is done. So for males, we need to look for the testicular, pre-testicular, and the post-testicular factors. So chromosomal abnormalities needs to be ruled out, and then the CBAVD and the cystic fibrosis related variant for the male factor. And for the females also, we need to do the chromosomal analysis to rule out any mosaic status or Turner syndrome or any other chromosomal abnormality, in addition to other monogenic causes of female infertility. And androgen insensitivity syndrome also remains an important cause.
So basically these chromosomal abnormalities, especially XXY, the problem is that it may get transferred to the baby because of ICSI. So that is a main important issue. And once we got prenatally detected XXY, and when I was talking to the father, because IVF was done, and I was wondering whether he himself had Klinefelter syndrome or not. So sometimes that screening is not done for the family, and that may also lead to sex chromosomal abnormalities in the conceptuses.
Yes.
Dr. Ashwin, do you have any special point in mind for counseling regarding infertility?
So as you said, one is XXY, the second is Y chromosome microdeletions. So these both conditions, doing ICSI, we need to counsel the family that the child is again going to be infertile because the same chromosome we are introducing there. And secondly, special counseling means infertility sometimes maybe because of balanced chromosomal translocations also, which results in early abortions, and also doing karyotyping, we are able to detect them also. So these are the special situations like Y chromosome microdeletion and XXY when we think of ICSI.
Right. So these balanced translocations are the ones where really pre-implantation genetic diagnosis is indicated.
So for trisomy 13 and 18, when we compile our data, so we had 4 trisomy 13 and 4 trisomy 18 and 2 trisomy 13. So there only 2 had trisomy 18 like features, and trisomy 13 was false positive. So even if in the absence of ultrasound abnormality, the result was positive. So I think this NIPS is best for trisomy 21, followed by 18 and 13. For autosomal, it is surely indicated for autosomal aneuploidies.
Right. So some of the trisomies, most of them have some ultrasonographic abnormalities, and naturally, even if trisomy 13 or 18, the burden of these diseases is less as compared to the burden of a child with trisomy 21 who will continue to live for a long time, and hence probably missing trisomy 13 will have less impact on a family sometimes, especially than missing trisomy 21. And hence the point to stress is that prenatal screening for trisomy 21 is very, very important. And if there can be some cost-effective method so that even other disorders are not done, but we can do 99% screening positive 99% effective method for trisomy 21, that would be the best thing for that. And hence I would lastly ask Dr. Ashwin, what will be your suggestion to plan a screening program at NIMS Hyderabad? So
yeah, so
we have to have some cost-effective method. Their patients are not going to pay.
Yeah, so so overall, whatever we have been discussing till now, NIPS, although it's a screening test, but we are really offering it as a diagnostic test. Like when screening is something which has to be done for the whole population and not for selective. But what we are doing is whoever is able to pay, they are doing, and that is why our statistics that we get is not really going to be the way Dr. Anthony showed. When you do screening for a large number of people, then you really get to know the cost benefit analysis and what is the use. So if we plan to do really at the screening level, then probably you would like to include mainly trisomy 21 for doing screening, because including more number of diseases, always there is the problem that you are going to have false positives, and then you are going to have more procedures that you are going to do. So when you're planning screening program from a public health point of view, you really would like to select the diseases which are really going to be of benefit with the least amount of problem that will happen to the patients, either monetary to the public health agency or to the patient by way of excess procedures that we are going to do because of the low positive predictive value. So we would prefer to do a screening for mainly Down syndrome if that comes to planning for a screening program.
Primary screening mainly. We are doing secondary screening in majority.
Right. So and that's why I said that for those who can pay, and then if they want to have because then when we say 99% diagnostic rate, so if you already do double marker test or something and then you have already lost the 30% of Down syndrome babies. So NIPS, if it has to be done, then it has to be done for those as at a primary level around 14-15 weeks, and then for those who can pay and they want to get best screening test done, but they also want to avoid invasive testing. So I think the purpose is that if you do after double marker, then those double marker negative 30% Down syndrome are already lost. In spite of doing the costly test, the purpose is not served. So basically, and the whatever cost 5,000 or 9,000 or 10,000, that population-based screening will not be cost effective in our situation, because the test Fetal is very costly and the government cannot have such type of program. So basically, if you are offering for individual base, then you should decide which individual needs that test. And once the any screening test is positive, like quadruple test or double marker, then doing invasive test and then microarray will detect more number of children with developmental disabilities. They will diagnose Down syndrome as well as they will diagnose other cases. And if you do 10,000 rupees NIPS, and then you will only diagnose Down syndrome, and you cannot diagnose others. So basically, we need to have a proper guidelines for our situation. Like every country has their own plan depending on their socio-economic status. So we need to have our plan for our situation. And again, the point to tell everybody should think in mind whether really screening for sex chromosomal abnormalities is necessary or not. Diagnosis, as I again said, if you do amniocentesis, you cannot avoid. But just for screening, whether they should be included in screening or because the laboratory offers, you just take it as because it is available. So that probably the society of fetal medicine society has to really think what is good for us, our patients and the society. And just telling the patients, you decide yourself whether to terminate XYY and put the ball in their court is not correct, because if they terminate triple X and XXY, we are also party to that termination because we had offered the test. So I think I would end this by thanking everybody, and I think there is enough points to really ponder upon at night if you are not sleeping well. Thanks a lot. Thank you, Shagun and Dr. Khurana and everybody. Thank you very much.
Thank you.
Thank you. I know this has been a very, very extensive evening, but thank you so much, Dr. Phadke, and all our team members here for staying on for so long. An excellent panel that we had, very, very informative. But there's one major message that I seem to have got during this entire thing, and that was that what next in terms of genetics seems to have emerged as a major dilemma in the minds of everyone who practices fetal medicine, and for all of us, and the obstetricians as well who attend our webinars, and the radiologists. And maybe we should really get together and do just a what next webinar. I think that would be the answer that we have. What do you think, Shagun? Should we do a what next webinar pretty soon with only a question answers without actually having any other topic? We did it for
In fact,
NIPT.
that's what I always thought, that probably a lot of people should send questions beforehand. We don't want to have the questions beforehand, but you should have, so that you can categorize those questions into
Together.
different beans.
Yes.
And then make representative 5 questions from each bean, and then it can be discussed, because ultimately everybody still has a lot of dilemmas. So really what they want, we would like to answer rather than what we want to tell them.
Which is true. And because
you just collect questions and then categorize them into similar patterns of questions, and then make representative question out of that, each pattern, and then we can discuss those issues.
I think Dr. Ratna has something planned like that for the next session.
Tried that for the last session of gestational genetics. We didn't get too many inputs. Then we did a poll. We did a poll of about 10 questions, and maybe we'll make something out of that together.
You can ask everybody to send questions.
I did.
I
didn't get a response.
We had a very poor
response.
Yeah, the best response is
WhatsApp group, so everybody is very active. See, whatever their personal experience case, so uske base pe they can ask, in that situation what should be done. So maybe I think give it a try once again.
Yeah, we will give it a try once again, and I think every one of us needs to work together so that everyone in SFM can then benefit from this. And we also have a lot of attendees outside SFM who can benefit from this, and we'll be only too happy to share that. I think we organize this between all of us who are still on the forum here, that we will go ahead with that. Yes, we have a few more questions that are still left in the question box, but I guess we'll really keep them for that what next session.
Keep those questions for the whatever you want to plan.
Absolutely, yes.
Right.
We'll do
Okay,
that.
thank you, and sorry for delaying, but I think people were listening, so we continued.
So over to Shagun for her closing remarks, of course.
Yeah. So it's been a wonderful session, and I can just kind of thank SFM to giving me this opportunity, and Dr. Khurana, Dr. Ratna, who really helped me design this program also. And of course, thanks to everybody, all the faculty and the participants who are still there at 12 midnight. So taken it to 23rd September. So thank you, everybody. Thank you.
Thank you.
Thank you. Good night.
Thanks to our back-end office, Vishal Mithal, for all the help that he always gives us. He's here inside being at work since 6 o'clock in the morning. And thanks to our trade partners for the huge support they've given us for this program. And of course, to Conferences International for being with us there always to make sure that the technology of our Zoom meetings is flawless. Thank you very much indeed, everyone, and good night.
Thank you, sir. Thank you.
Good night. Good night.
Good night, everybody.